Pancreas program and access program at the University of Colorado. And my co-moderator, who many of you know, Dan Dent, the former program director and now the vice chair of education at UT San Antonio. And we're going to have a panel discussion about competency-based education and the use of Entrustable professional activities to achieve it. And so we have a panel of experts that are going to talk about this in succession, but I think it's important that we try to make this as interactive as possible. I noticed everyone is in the back, but please don't feel like you need to be far away. We want to make this interactive and fun, and enjoy your food. And thanks again to Southwest Surgical Congress and Margie and Jill for putting on another great event. So Dan is going to introduce our first speaker.
Absolutely, thank you. So our first speaker, we're going to work our way through the continuum of medical and surgical education, starting at the student level and working our way up to the fellowship level, and how these things may interact can be some of the discussion at the end. Our first speaker is Dr. Sasha Adams. Sasha is a trauma surgeon and the residency program director at UT Houston. And more importantly, for this task, as I looked to find speakers that could speak to EPAs at the student level, which are being done in 80 medical schools across the country, there's only one surgeon in that group, and it is Dr. Adams. And so we are very privileged to have her here to be our first speaker.
All right, well, good morning. So yeah, becoming involved in this project was rather interesting, and I'll tell you a little bit about how I got involved as we go. So I'll talk about the EPAs at the medical school level. My only disclosure is that, as he said, I was a part of the pilot study group of UMEs and the core EPAs, which is just travel costs, so nothing great. So we'll review some of the goals of the continuum of medical education and talk about some of the background and creation of the EPAs in the UME. One of my first steps is I had to learn what all that meant, and then current status of how it's being implemented in the medical school. So conceptually, when I think about a continuum of education, it seems very much like to me, of how a child grows through stages of development. You learn skills, acquire knowledge over time, but unlike a child raised by a family unit, in medical education, this is done in multiple different institutions, multiple different rules, responsibilities, levels of risk, and different governing bodies. And so the other part of it is the individuals passed off between these institutions as they progress through that continuum. So it's much more like a series of locks. So again, each at a different institution, you have medical school, moving on to residency, then on to fellowships potentially, and then into practice. And along each one of these phases, the rising water level correlates with the accumulation of knowledge and skills. So this is the competencies. These are observable, trainable abilities related to a specific activity that's integrating the knowledge, the skills, the values, and the attitudes. Again, within each of those phases, as that water level rises, there are milestones to judge how far they have gotten. And so the milestones are definable, observable markers of that individual's progression along that continuum of development. And then at each new level, there's an expectation that the level before completed all of those tasks, right, reached all those levels of competencies, and that the person is prepared and ready to do what you need them to do in your phase of training. And this is where the Entrustable professional activities, the EPAs, come in. So a task or responsibility that a trainee can be trusted to perform without direct supervision as of day one. So in 2014, about 1,600 program directors were surveyed. This included multiple different specialties: internal medicine, family medicine, psychiatry, pediatrics, OBGYN, and yes, surgery. And about a third of them responded, and they were asked a very specific question. Considering only the PGY1 residents in your program who are graduates this year from LCME accredited US schools, how many residents were you confident that they were prepared to do the following without supervision in their first week of residency? And the answers were no, few, some, most, or all. And I don't know about you, but as a program director looking at this level of confidence, this is incredibly alarming. And I would agree with it in my own experience as well. You have a variable level of ability when the students come through as interns to perform these tasks. So as a result, the AAMC commissioned a 15-member panel because there was this problem, right? The medical school progression to residency and fellowship was not ready. So they commissioned this 15-member panel across the continuum, meaning it included resident educators as well as interns and residents and educators within the programs. And they were tasked with defining those activities that all entering residents should be able to perform on day one. The difficulty unique, I think, in the undergraduate medical education, the UME setting, is that these individuals are going to progress into all different specialties. So the activities that are going to be core activities have to actually be core for every specialty regardless. And it's very broad then. So the AAMC identified these 8 areas of competency domains. You'll notice that they're very similar to what are the GME and the American Board of Medical Specialties, broad again. And they had added 2 additional, the interprofessional collaboration and then the personal and professional development areas. And then they took these core abilities and made them into a task. List of tasks that the residents should be able to perform. Time frame on this, by the way, is around 2014 is when the core EPAs were being developed for undergraduate medical education. Okay, so then they identified these 13 core activities that should be able to be done on day one. Gather a history and physical, yes. Prioritize differential diagnosis. Recommend and interpret common diagnostic screening tests. Put orders in. Know why you're putting them in. Document a clinical encounter in the record. Do an oral presentation of that patient encounter, and then have questions and be able to research those questions to come up with the next set of answers to treat your patient. Do a patient handover safely. Collaborate as a member of a team. Recognize and triage patients who need emergent care, and then get consent for tests and procedures that need to be done. Perform general procedures of a physician. As the surgeon in the group, I will say I raised my hand on that one. I was like, what exactly do you mean? Again, very broad. This is literally IVs, bag mask ventilation, CPR, and phlebotomy. And then identify system failures and contribute to a culture of safety and improvement. So they commissioned this 15-member panel. They came up with these 13 specific areas. And then they also went and they said, okay, well, we've got to figure out how to implement this well. So they developed this group and said, okay, these are our goals. We want to have safe and effective patient care. We want to ensure that every graduate from every medical school is prepared. And we need to also figure out how to put this in a framework that can be spread across all of the medical schools. And develop objectives and summative determinations to know when the student is ready to progress. In other words, when are they entrustable in all 13 areas? And so to do that, they actually then created a pilot study. And so they have 10 participants from around the country, and they're listed there. And these are the core EPA pilot programs. And each one was tasked with the responsibility of tackling 1 to 2 of the miles of the EPAs, and figuring out how to operationalize them, how to measure it, how to evaluate it, and then how to create the entire toolkit that then could be passed on to other institutions who then were also going to try to implement this in their own institutions. This group then did work together quite well. They met every 6 months. Originally, it was a 5-year plan. It did get extended beyond that because, as it turned out, they weren't able to complete the work because this was far broader, I think, and more expansive than they originally anticipated. There's been multiple publications from this group, mostly has to do so far with the process of choosing those 13, how they chose, how they worked together, and what the foundational educational values were associated with this. But they also created these toolkits, and this is all available online, accessible to everyone. And I'm going to go through one of the toolkits, just a couple of the slides, just to kind of give you a scope of what they've created. So this is for gathering a history and physical examination. And I know that the type is really small, but just kind of the big things to point out is, if you're going to say whether or not a student has the ability to be entrustable without direct supervision, that far right is going to be that entrustable activity. So it talks about what specific details in what they can demonstrate would give you the impression that they're entrustable. And they've talked about key ideas and then progression, kind of like a milestone format to reach that. And if you're interested in kind of how this sits with the domains of competence and competency requirements, they also broke it out in this way as well. So some of the challenges that we've seen in the undergraduate implementation of the EPAs, it is incredibly broad. And I think this is one of the things that made it really difficult for this group. It is not specialty specific. You had to stay in something that was based to all. We found that the language that the UMEs had prior used in assessing a student ability was not aligned with what is expected in the GME level. And so that had to be changed. What about how are you determining whether or not the student is ready? Well, who's doing the assessments? A lot of times our students are spending a lot of time with junior physicians. Are they schooled in understanding this? The faculty needed faculty development activities as well. And of course, observing this is happening in clinical environments, which is challenging already, but often because of workload and levels of supervision in different environments. So to get these done well, feedback and resident assessment skills, again, coaching skills, what do you do when the student is not adequately meeting those goals, and how do you address that with them? So this was one of the more recent publications. This one's actually an EPUB ahead of print, which is exactly one of the things that we debated at length at these AAMC meetings is how are we assessing it? So there's two current scales available for entrustment, the Ottawa and the Chen. And this group did a long study over a year and found that there was more variance due to the person doing the rating than there was in the performance of the actual student. So this is a really fundamental problem of how we're progressing. And this is where most of the work is continuing. There was some improvement with frequency of use, which gets back into the faculty development and better understanding of how we are assessing these. So summary, the goal I think is excellent, right? The core EPAs have to be reliable in assessing a student's ability to perform specific duties of an incoming intern. We are still not sure though about the reliability of the measurement scores we have available and the generalizability, meaning if my school says this person's the same, does every other school agree? And can the accepting residency program rely on that? Students also need to be very clear on their expectations and feedback on the ability to meet those EPA goals. How are we going to do corrective action, especially when there's a lot of variance in this ability to measure? And then I think the medical schools really need feedback from the accepting residency program directors on the readiness of their students to perform, including the MSPEs and how accurate they are. So with that, I will pass off. Thank you.
Thank you, Sasha. So I think we'll just have everyone talk, and then we'll have the panel discussion like we've done in the previous few meetings. So next up is Ken Murayama. He's a chair and program director at the University of Hawaii, and he has had a very distinguished career in surgery and education. And he's going to be talking about this along that same continuum as Dan was mentioning from the American Board of Surgery.
So thank you, everyone, and thank you for that nice introduction. The first disclaimer I have is that I am no expert in EPAs, and I think talking with Dr. Richmond, who he and I are both speaking on behalf of the American Board of Surgery, we're on the General Surgery Board, and you might ask yourself why the board is undertaking this. And really, if you think about what the American Board of Surgery does, one of the things they do is ensure competency of people who are going to be certified to be surgeons. And so there's an investment by the board to make sure that they're a part of the EPA discussion from the standpoint of competency for surgeons. So the American Board of Surgery, the American Board of Medical Specialty statement on competency-based medical education during COVID residency and fellowship disruptions was printed. And this statement, I sort of blew it up, but obviously I'm no expert at highlighting a digital document. So basically during COVID, people came to realize that we needed to ensure that our surgeons were going to be competent, that we turned out. So they organized a group of organizations that were invested in graduate medical education and came together to work on the concept of EPAs for surgical training. All right, so what is an EPA? You heard about that from the previous talk, which nicely summarized all of this. But from the ABS standpoint, it's an entrustable professional activity. That's what it stands for. And it's basically, do you trust someone to do a task? Can you trust that person to do a task, either with or without supervision? So it's a tool for competency-based medical education. I think you all have lived through a period where training has been purely time-based. Interestingly, before we went to a time-based model in the Halstedian era, it was competency-based. And so we're headed sort of back to making sure, I believe, that we can actually assure competency for the people who are finishing. All right, so it's a unit of professional practice or tasks that can be entrusted to a learner to execute ultimately unsupervised. But think about how you get people to that unsupervised state, and it does take up, you have to go through that process. And then once that person has demonstrated the required competence, you can entrust them to do the task unsupervised. It's a shift of focus from individual competencies to the work that must be done. And that seems a little enigmatic, but it's really, we're not looking at specific tasks as much as the global, can you do an operation? Can you do the whole scope of work? All right, so you heard about it at the medical school level with the AAMC. The board is very focused on the concept of EPAs in surgical training. And you're going to hear another talk from Dr. McBride about the EPAs and fellowships. So, and again, this is a AAMC core EPA project. You heard about this, but basically to summarize, they felt that medical students were not being prepared well for the expectations when they come to residency, hence the plan that you heard previously. And I won't go through this partly because the highlighting is not so good, but also because Dr. Adams went through all of this already. So we're not going to dwell on this, but there are some key things that the AAMC came up with that students needed to be trustworthy to do when they come to residency. And when you look at the list of things, it is really things that we expect an intern to be able to do. So I think they're spot on with the expectations. From some things as simple as getting a good history and physical to being able to do a good patient information transfer, do a consent, and simple procedures. All right, so I won't get into the fellowship level EPAs much, but just know that the Fellowship Council did perform a pilot of EPAs in the 2020-2021 academic year, and they're in soft launch. You can see some of the different fellowships undertaking EPAs, and then endocrine surgeons also, through the American Association of Endocrine Surgeons, is undertaking the development of EPAs. All right, so they're work-based assessments. It's a holistic assessment from the standpoint that you're integrating all the competencies we expect of our competent graduating residents. It is learner driven. It does require the learners to actively participate in their education, and it is directly observable. So it's basically observing them completing the tasks or the EPA that they're undertaking. The observation is frequent. It's ideally going to be associated with every resident interaction, but I don't think that it's obviously a stepwise process to get to that point. And it's not the same as the end of rotation evaluation, which I know as a resident you dread, and as a faculty member you really dread, right? So it's based solely on the interaction being evaluated for that specific EPA. I think you would all agree that our current evaluation process, for the most part, is inadequate in determining true competency. So the level of entrustability for the same EPA may change based on the clinical context. So you could have a sicker patient, you could have a patient who has significant other comorbidities, more difficult interpersonal interactions, or just a harder case. So it just depends. So it's not square peg only. It can be, you can modify as you need to for the individual patient situation. So why EPAs for surgery? I think I highlighted this for you. It's really because the board is about ensuring competency for the people who are going to go out there and practice. So it turns that equation into a partnership between the learner and evaluator. And I think that's key. If you think about when you evaluate residents or a resident, if you're a resident being evaluated, it feels very hierarchical. You're being evaluated top down, and it makes it very difficult to have a true constructive interaction. So it places emphasis on the learner to seek out the evaluation opportunity. It asks the evaluator to assess trust, right? It changes the frame for that conversation because now there are clear tasks that the resident is to complete. It provides clear anchors for evaluators. I think with Likert scales that many of us use in evaluations, it's always about the anchors not being clear or not being appropriate. And it's part of the workflow and these anchors should be meaningful and substantial. And it's the issue around surgeon faculty burnout. So that issue has come up in multiple discussions because when you first hear about the EPAs and you look at what an EPA is going to entail, it does seem like it can be an onerous amount of work for the faculty member. And it definitely adds stress when you have to decide if someone's truly capable of doing an operation without you being present, right? So it gives focus to that encounter, and it improves the faculty engagement and, in theory, the morale, right? And that's based on the pediatrics pilot with EPAs. So it's not a perfect system, I'm sure you all recognize that, but it does really involve the engagement of both the learner and the faculty member, and it's got to be a partnership when that happens. All right, so I'm going to turn it over to Dr. Brian Richmond, who's the current president of the Southeastern Surgical Congress and is a guest of the Southwestern Surgical. And he and I split up the slides that the board provided to talk about the EPA. So he's going to take you through the rest of the slides here. So Dr. Richmond. Sorry, I stole.
Thank you, Ken, and thanks to the Southwestern for the opportunity to speak on this topic. I also share Dr. Murayama's lack of expertise in this matter, but I do find it very interesting, and I hope we can all learn something today. So the ABS has taken this project up. They've moved all in on it, but they're not working alone. They're working, of course, with the ACGME and with input also from the YFA and the RAS. EPAs are not new. The original Halstead residency was a competency-based assessment that based advancement on acquisition of skills, not an arbitrary time frame. So it's certainly nothing new. The Netherlands has been using EPA-based assessments since 2005 with success. The Canadians have a similar project known as Competence by Design that has many of the similar benchmarks for advancement. And within the United States, the American Board of Pediatrics is currently using EPAs as their form of assessment for advancement. It's important to know that EPAs by themselves can be discrete or quite broad. This is an example of a broad EPA. Let me read the gallbladder EPA to you. Gallbladder disease is a condition commonly encountered by general surgeons, both in the elective and emergent care setting. The essential function of this activity is the definitive treatment of the spectrum of benign biliary disease, as well as the recognition of diseases requiring specialty referral in both adolescent and adult patients. So that's a very broad definition of an EPA, and certainly too broad to make a single assessment. So the concept of EPAs is based on multiple assessments, the identification of specific anchoring behaviors collected over time, so that when a CCC meets, the decisions aren't arbitrary. They have data to base them on. The EPAs have 5 levels of entrustability. The first is observation only. The second is can perform under direct supervision. The third can be performed under indirect supervision. The fourth, the task can be done unsupervised. And then the fifth, the trainee can actually take a teaching role for a junior colleague. This sort of explains that more in detail. As you can see, the observation or can act with direct assistance or direct supervision is pre-entrustable. Doing the task independently but with backup close by is provisionally entrustable. And then 4 and 5 is acting independently without immediate backup and assuming the teaching role. This is an example of an EPA microassessment for the preoperative assessment of a patient with an inguinal hernia. If you determine that the candidate or the trainee does not understand inguinal anatomy, has major items of the history or physical examination missing, they cannot generate a differential, their informed consent is complete, or they don't understand the basics of hernia management, then they are in the phase 1, they cannot do, they can only observe. This is an example of the third phase of entrustability. This is provisionally entrustable. In this case, the trainee can do the task with indirect supervision, and the attending occasionally has to see the patient and check their work. You can see the elements there. They have an advanced understanding of the anatomy. They have a focused and accurate H&P. They generate a complete omission. They're able to generate a differential. They're able to perform a cost-effective workup for most patients. They have a textbook level of understanding of hernia management. And they have a clear and complete informed consent with most patients. And then finally, in the 5th stage of entrustability, once again, they're essentially able now to perform independent work and to teach those junior to them. So the ABS conducted a pilot study. It spanned 2 years from 2018 to 2020. And the purpose was basically to assess the feasibility of EPA's assessment in a variety of training programs. They also wanted to determine the number of microassessments that would be necessary to make a summative entrustment decision with confidence, and also to filter out any subjectivity in the assessment process. It was a 2-year longitudinal multi-center study, and the data collected involved number of assessments, entrustment level, the confidence in the level of entrustment, and achievement of milestones. It was conducted in 28 pilot programs. 24 were traditional medical school-based programs, and 4 were conducted in independent academic medical centers. The requirements were basically an experienced PD and a willingness to participate with an adequate infrastructure. The microassessments were recorded in an app that was designed specifically for this purpose. The 5 EPAs that were chosen were manage a patient with an inguinal hernia, manage right lower quadrant pain, management of a patient with symptomatic gallstone disease, provide a proper general surgical consultation, and to evaluate a patient with blunt or penetrating trauma. There were 1,115 residents in the program, 6,236 total observations, which was an average of 5.6 observations per resident. Residents who received at least one actually received a little over 7 observations, which means, frankly, some residents did not have any observations recorded. The source of the faculty observations were surgical faculty in 85%, and then ancillary faculty in 15%, which consisted of hospitalists, ER doctors, and advanced practice practitioners. When the faculty was surveyed, there was general consensus that EPAs could be integrated effectively into the daily workflow in both preoperative, intraoperative, postoperative, and in the development of consultations. The residents' surveys were similar. Once again, preoperative, intraoperative, postoperative, and in the ability to perform an adequate consultation. The other thing that was noted was as training progressed, generally speaking, by the PGY 5-year, the majority of residents achieved entrustability at least at a level 4 and many at a level 5, meaning they could practice independently or assume an educational role. Some early lessons learned. Everyone agrees intraoperative assessment is the easiest part because you're directly observing the resident performing the procedure. Pre and postoperative care is less frequently observed, and that may need to be specifically assessed as a skill as you would in an operative setting, but actually observe the evaluation. This is also where hospitalists and emergency medicine physicians can weigh in, since the residents are typically providing services to those disciplines. It is possible and feasible to collect a large number of assessments. The rollout is going to be key. Everyone realizes this is a radical paradigm shift, and education is going to be necessary, and the effectiveness at which the faculty are educated and the residents are made aware of the process is going to greatly affect the success. We're recognizing the value of non-surgical assessors like ER doctors, hospitalists, and advanced practice professionals. And the resident buy-in to this process appears to be quite good. There is literature published on this in the Journal of Surgical Education and in Academic Medicine. I would encourage you to read it, and I could provide you with those references if you'd like. And meanwhile, I'm a little over time, so I will close and look forward to questions at the end of the session. Thank you.
Our next speaker is Dr. Corey McBride. Dr. McBride is a professor of surgery at the University of Nebraska. She serves as the chief of minimally invasive surgery and bariatric surgery, and she has led efforts by the ASMBS and the Fellowship Council on entrustable professional activities for fellows. She's currently on the executive council of the ASMBS and the board of the Fellowship Council, and she's going to teach us about EPAs at the fellowship level.
Thank you very much. These are my disclosures. None of them have any financial relevance. The objectives, as already stated here, so I'll go on. Some of the previous speakers mentioned, we've really worked in this historical model, and fellowship is probably the best demonstration of this. It's 1 year or 2 years, depending on your fellowship, and there may or may not be rotations, but it's all about the case logs. Did you get enough cases? In bariatrics, the holy grail is 50 anastomotic cases, or did you do enough Whipples? And so it's all about, did you get the cases by the end of the year? But we all know that completion of cases does not mean competence in cases. Plus, especially if you look at resident case logs, they self-report what they did. We've all seen those resident case logs where they were the surgeon for every operation they did for their entire 5 years. And I'm sorry, interns aren't doing Whipples and hepatectomies.
And then they have their written evaluations at the end. And really, that's what we're trying to get over. Instead of numbers being the surrogate for competence, we want competence to be the surrogate for competence. And the previous speakers have already told us about all the previous tools we've been given. We've been given the competencies, we've been given the milestones, but I don't know about you, but when I look at a trainee, my brain doesn't say, they seem to have gotten 75% of all their milestones and they've done this and they've done that, therefore I trust them. What happens is you watch them, and at the end of the day, your gut says, do I trust them to go to the ER and see that patient? Do I trust them to walk into that exam room and be the face of me and be the face of my practice? Do I trust them to start the operation or do the operation skin to skin? It's all about trust, and we have to make the decisions on whether we trust them every day. So you've seen other definitions of an entrustable professional activity, but really when we were trying to do this at the fellowship level, the first step is to define who we are. What is a bariatric surgeon? What is the core to being a bariatric surgeon? Is it that you have to be able to do a primary case, a revision case? And then you can say, what are the activities I have to be able to trust? Bariatrics did it, hepatobiliary did it, Flexendo did it, and Abwal did it. And so each fellowship has to define who they are, and then what are the activities you have to be able to do, and then what are the things we have to be able to trust our trainees to do. And that's how you come up with an EPA. So this has been done at the medical school level, as the previous speakers pointed out. The American Board of Surgery started with 5. They just within the last about 2 weeks shared with us the next 14 that they're going to work through as they're defining what is the core of being a general surgeon. And the Fellowship Council has been working on what is core to these fellowships. So as I mentioned, initially, several fellowships were all working and they were working in silos. And the Fellowship Council came together in about 2018 and realized that the fellowships should not be doing all this work individually because there's a lot of crossover. While the bariatric fellowships may create EPAs related to bariatrics, foregut fellowships may actually look at that list and say, you know what? Our foregut fellows still should be able to do some of those things. Or the bariatric fellowships may look at the list that the Flexendo people put together, and they'll want to use the EPAs. So rather than every fellowship creating their own. So the Fellowship Council put together a group that they called the Unified Standards Task Force. And we all got together. It was actually in a ballroom a lot like this. And we started saying, what is core to each of our professions, but where does the crossover exist? And so what ended up happening is we put together 5 big working groups to create the initial EPAs for each of our specialties, with the intention that colorectal and thoracic would come along later. And the EPAs were written for each of these groups. And as I believe Dr. Murayama pointed out, we did a first-year pilot, and we're actually in the 3rd year of piloting those first 5 groups. So this is how it kind of works. So there are some of the EPAs that have been written that are only about preoperative care of the patient. So for example, there is an EPA for the abdominal wall group that only has to do with, can you properly prehabilitate the patient? Can you identify what they might need? Can you identify how to get them ready? So if I saw a 63-year-old male patient with a BMI who's smoking, who has a large ventral hernia, I could have the fellow go in, I could have the fellow see the patient, and I could have them come out. And if they can present the patient and create an adequate plan that adequately prehabilitates, I can decide, are they trustable? And the levels of entrustment, if they come out and they're a complete dumpster fire, then they are not trustable or a level 0. But if they can start putting a plan together, but really they need coaching, they need significant supervision, it's a level 1. And the levels go all the way up to level 4. Wow, I can completely trust them. They are practice ready. They got all of the things and it was done in a timely and an efficient manner. On the other hand, and all of our EPAs do end with, because this is a digital platform, where you should comment on something they did well and something that they can improve on for next time. Now, other of our EPAs follow much of the same format that the ones structured by the American Board of Surgery do, where there's a pre, intra, and post-operative phase of care. And so if I was seeing the same patient with my fellow, a sleeve to bypass potential patient for severe reflux, if it was in clinic, I could evaluate their preoperative decision-making. Intraoperative, their intraoperative skills, or postoperatively, how they manage them either in the hospital or in clinic. But for example, looking at the intraoperative, so I pick which phase of care I'm going to evaluate them. And then again, how much trust? Did they watch me do the case? That's a level 0. Were they acting as a first assistant? That's a level 1. And then depending on how much of the case they did and whether I was being a very active first assistant, whether I was being a passive first assistant, all the way up to level 4, where I didn't actually have to scrub in the case. Now, obviously, we do have to be careful because it is written in such a way, because some places the attending not scrubbing is not an option because of med staff policies or legal. So it is not written such that you don't have to scrub, but that you essentially provide no assistance during the case. And again, what did they do well and what do they need to improve? So we've had these EPAs out there for 3 years that they could be done. This is what these are the current 7 that are available for a bariatric patient. And it's basically, and this is what we consider core to bariatrics. And I only put this out there as an example because there are 7 bariatric EPAs. And right now to do a bariatric fellowship, you have to do all 7 EPAs. But part of the reason this was tackled by the Fellowship Council is foregut has 5 and ABWAL has 7. And so there are also fellowships that are a mixture of different fellowship types. So for example, there is a fellowship type called an Advanced GI-MIS fellowship. And so instead of saying, they actually like pick from the menu. They say you have to do 5 of this EPA type and you have to do 2 of this EPA type. And this is why the Fellowship Council was really a leader in this space, because they basically created the menu of EPAs, and then the fellowship sponsors went through and they pick which EPAs are germane to that fellowship type. And this is why it gets a little confusing at the fellowship level. Now, as I mentioned, and we're in the 3rd year of this pilot, and we also have had quite a few lessons learned. First off, we actually found some EPAs that we forgot to write, and we had to go back and write them because we realized we had gaps. We also found that we needed more education for the faculty and fellow, and we've certainly improved the training and onboarding at the beginning of the fellowship year. We unfortunately do not have an app like everyone else, and we are working on that. And we are using these, we're creating a dashboard so that the EPAs can be used part of the clinical competency. And then the final challenge we are going to have, now that the American Board of Surgery has released the list of what the full 19 EPAs are going to look like at the completion of general surgery, you can actually see that there's going to be overlap between the end of general surgery and the beginning of fellowship. So we're going to have to go back and probably rebuild some of ours, because if you're supposed to be competent in inguinal hernia at the end of general surgery, then why do you need a fellowship inguinal hernia EPA? And so that is work we are going to have to do to go backwards. And that is, I am also over time, but I look forward to questions during the panel. Thank you.
Well, we welcome questions from the floor, but to get things started, I've got 2 questions. My first one is for Drs. Adams and McBride. Talking about faculty acceptance or buy-in on this, you said like the pediatrics pilot has shown that the faculty actually like it. And the way it was sold to me is, if you ask faculty, how good is Dr. Susie or Dr. Freddie at problem-based learning or systems-based practice, their eyes glaze over, as do mine. And I've been in this education game a long time. I'm still not exactly sure what those terms mean. But if you ask them, do you trust them to manage your patient with right lower quadrant pain? That's a conversation we're already having, right? The faculty already have that conversation about the resident. So you're actually asking them to put it in terms of the thing that we get up every day and are passionate about, and in a context that we really kind of understand. But how do we get from knowledge of that concept to actual adoption and buy-in from the faculty such that they'll start evaluating residents in these terms?
I was going to say, I think you answered the question by meeting them where their interest is, right? So if you say, well, can you trust this person? Well, are you interested in your ability to trust that person to do X, Y, Z? Yes, I am, absolutely. So how can we define that trust? How can we also share that information? What if, Dr. Smith over there says she trusts this resident to do that? How do you reliably communicate that same level of trust with the same meaning? And I think that's honestly the way to do it, because like you said, we're all very passionate about what it is that we're going for. And so meeting people where their passion lies, I think, is the answer.
So actually, I do think at the fellowship level, it is a much harder sell, because when you have a fellowship with only 2 attendings and they only train 1 fellow a year, many of them say, why do I need to fill this thing out on the app? Because I'm talking to my fellow every day. I see my fellow every day. But when you actually survey the fellows say they're not getting feedback. They are not getting constructive, usable feedback. And so you have to really, while you think you're talking to them, what you're talking to them about is sports and music and everything else. You're not giving them constructive feedback. And so we just have to make it clear that the fellows are not necessarily getting what they need. And our goal as educators should be to give them that constructive micro assessments so that they are getting better in the way that we want to be helping them get better.
Could I? One of the things that I think is most attractive as an educator who's being challenged to adopt this is just that this does make it more tangible and discrete as to what we're supposed to be evaluating. I've always found the description of the competencies fairly nebulous and really hard to pinpoint, what is adequate and what's not. So we kind of went to the gestalt to say, basically, I trust this person. The EPAs discreetly identify the anchoring behaviors that are important in every area, and I think give us much more to work with in terms of standardization and execution objectively.
And if I could add, just on the student side, I think there's a totally different set of challenges. And I think a lot of that has to do with opportunities for observation. And I think at the student level, what's going to end up being really productive is structured observation, like OSCEs, for example, is going to be the way to find those.
All right, thank you all. I think it's a great panel, important topic. So it's funny to me that there's only one surgeon in the medical student panel, and Dr. Adams, thank you for representing us, because this is a very surgeon type thing, right? It's concrete, it's tangible. I mean, it seems very surgical to me, so it's odd to me that we're not more at the table. But as Dr. Richmond pointed out, there's a big difference between how the EPA is defined for surgical consult and gallbladder, right? I mean, that's crazy. To lump choledocholithasis, cholelithasis, biliary cholecystitis, which all fall under the spectrum of benign gallbladder disease in one EPA, only works if you then break it down into many mini EPAs. And the only way to be consistent is if we're all given the app or whatever it is that has all these mini EPAs on it, because I don't think that most PGY 2 to 3s, for example, are going to be at a lab CBD exploration level of competence on that disease, while they may be perfectly good at diagnosing and managing cholecystitis. And so how finely do we dice this? And who's going to do that for us? Because obviously an individual faculty member is not going to have the time to create separate EPAs for every aspect of the common surgical diseases.
So I didn't actually put on my disclosure slide. I actually was in the working group that wrote the inguinal hernia one, which I guess it's nice to see that it's held its test of time, that it made the slide deck. And right, I think that work of just to write the inguinal hernia one was probably, I think it was 2 trips to Philadelphia and weeks worth of work. And it was probably a one-day conversation to just even, will we call it inguinal hernia or will we call it right lower quadrant pain? I mean, we probably debated the title of it for a solid day before we even got into what would the next step of it be? Because right, it is an incredible amount of work to write these. And I applaud the group that is now going to tackle the next 14. We were very fortunate in Nebraska. Dr. Mary Klingensmith just happened to give grand rounds a week and a half ago. And she's the one who shared the list of the 19 that are going to be the next ones written. And if I'm remembering what she said when she shared that list, the way they generated that list, and please, the members of the board, correct me if I have the number wrong, but I believe that they came up with that list because that list will cover 90% of the cases that graduating chief residents come up with. So that is how they came up with that list. Dr. Mannon, you probably heard that same grand rounds. Am I remember, wasn't it 90%? Yeah. So that's how they came up with that list. If that helps understand where they came up with it and how they, but it's going to be an incredible amount of work to come up with those EPAs.
Yeah. I'll speak to that a little bit, Dr. Disanegi. The question becomes, are you a lumper or a splitter, right? You know, you could take, for example, the colon and you could divide it into malignant disease and benign infectious disease, or you could put it all together as colon diseases, or you could put it in a separate EPA of intra-abdominal infections, you know, and how we put these together is a lot of discussion and debate, like Dr. McBride said, and I've been in some of those rooms, and you want to just stick a needle in your eye at times as you're in a room with people who are your heroes and that you really love and trust as individuals, but you can't come to agreement at times on some of these things, and it's a real challenge. And just all I would ask is that the people that are doing this work, please give them your utmost respect, because it is hard and detail-oriented work. Jason.
Hey, thanks everyone. And I can tell you, I've been working with Jake and Mellinger, Greenberg and Mellinger on how do we roll this out nationally. And it is a huge task. We're in the middle of interviewing programs that did well, interviewing programs that didn't do well, interviewing residents. How do we put this together so we can roll it out in a meaningful way to all of the residencies, not just the pilot programs? And so adding in more and all of this. And hopefully our goal is to get a little toolkit like you showed for the AAMC for residency programs as we roll it out. But it is a very large task, I can tell you.
Can I have
Sorry, I got you.
sorry, comment and a question. So the comment is, I think we focused on the entrustability of the residents and the interaction between the faculty and the residents to get to the point where you can trust the resident to do something without your assistance. How are we going to train the public to understand that their operation is going to be done as part of the entrustability process for trainees? Right now, it's assumed. Patients don't want to know about it, but if something bad ever happens and they say, well, was the resident testing for being evaluated for level 5, which means you didn't participate? And so how do we educate the public that this is an important process for them in the future, that we are training people to be competent and not just based on 5 years varied competency at the end?
And I think it also depends on what the resident or medical student or learner is trying to accomplish. So, you know, one of the things was, can you take an adequate history and physical, and can you do informed consent? Well, I know, and probably many people have experienced this, but when you're an intern and you've been a doctor measured in hours and you get called to go do a consent form on a cardiothoracic operation for a baby, I don't really feel like that's necessarily the same idea as, you know, can you take a history for someone who's got some, you know, 20-year-old male who has new onset right lower quadrant pain? I think that's a very, very different thing. And this came up a few years ago when, you know, we used to have our interns trying to get consent for liver transplantation. And so the patient was asking a lot of questions, and this was an exceedingly intelligent young lady intern. And at the end, you know, when she was all done there, she mentioned to me, she's like, you know, it's absurd that I'm talking to this patient about a liver transplant. I've been in this institution for a couple of days. And she said, they asked me where the surgical incision was going to be. And I said, in the skin. So and she said that to me in jest, but the concept is that we have to have appropriate expectations and make sure that that as this gets rolled out and becomes more tangible, that it's done in a way that's actually doable. That's my 2 cents.
I would tell you that was one of the times in that room of all the medicine doctors that I was like, excuse me, like what you mean by consent? And so there are in that toolkit, I think there is, for example, a lot of specifications of consent for a procedure that that individual be expected to participate in at some level. So I think that's some help, but yes, I entirely agree.
Dr. Moore.
Thank you all for all your thoughts. And I guess my question, I was a prior program director, still very involved in resident evaluations. And I think one of the challenges obviously is just getting our faculty to complete resident evaluations. And listening to this, and not to be disrespectful, but I'm concerned that what we need to make it easier for them to give us information, because what we do know is that, at least in our experience, and it's a big program at the University of Colorado, Peter, you know that, I mean, 120 residents in various scattered, that's just the residents. What I'm getting at is 90% of those people are doing fine and are going to do fine. And we are measuring that, and we do need to measure that. But what we have to identify are the 10% that aren't doing fine. And how do we help those? Obviously also help the other ones. And somebody talked about feedback, and feedback needs to be very quick, very immediate, that kind of stuff. But what I'm getting at, how do you integrate this into that overall evaluation process to make it easier for our faculty to be able to get it? And also our competency committees to be able to assess somebody who's having troubles. So for anybody that's done that, for also a large number of people. And then secondarily, for the fellows at the end of the table from the board, is the board going to require this? We heard Dr. Klingensmith coming out. Is it going to be another one of the, like the OPRSs or the, the clinical evaluation tools? Are these going to be, again, another piece of information that needs to go into the file? So those are my 2 questions. Thank you. Thank you all for your time and work.
Well, I don't speak fully for the board, but I think we have 3 people on the board here, Dan Dent, Brian Richmond, and I believe that unless something drastic changes, the EPAs are definitely going to be a part of the future evaluation process for residents.
Yeah, the July 1, 2023 entering interns will have to complete all 19 EPAs to graduate. Yes, and so the board is actually has met with 3, and there's one other company putting a bid in for a software platform that will be provided free to every residency program. So it's not going to be an additional expense for the residencies to download or do the evaluations. And the thought process, it's a little bit of maybe a dream state, but the thought process is, if when a resident's on your service, you and your colleagues do enough evaluations of individual acts, that in and of itself becomes your end of rotation evaluation. So you no longer have to do the end of rotation evaluation. You can see that the resident on a 2-month rotation with you got 37 evaluations and was deemed, independent, worthy of independent practice on 32 of those. And they will be able to see relative to their peers how that is and which ones they came up short on, what procedures or whatever they weren't deemed independent. And that would be data that would feed to the clinical competency committee for decision making.
So just a couple comments. I think one of the points you brought up is not completely clear to me yet either. And that's how to identify the resident in trouble, not using arbitrary assessments, but rather within the EPAs. In other words, at what point should a resident achieve a level 3 level of entrustability, and how do you remedy that if they don't? Can we infer that the PGY 3 years should be a level 3 of entrustability? That to me has not been defined completely yet. And then I think the other thing to point out too is I do believe that the extra work is going to be in assessing the pre and post-op and consultative areas, just because as it stands right now, those behaviors aren't as observed as directly as the intraoperative assessments. And that's something that definitely came out in the pilot as well.
Right. The literature I've seen, so Canada is way ahead of us in this. And the data out of Canada is that you really need probably somewhere around 40 assessments per EPA to get good interrelator reliability and consistency. And I can conceive of how that's possible for most of the intraoperative assessments for the things that are being picked in general surgery. But then we're really going to have to focus on the pre and the post-op to ensure we get it. But as someone who's mostly focused on fellowship, I don't know how we're ever going to get 40 assessments for some of the things we've picked for one-year fellowships. But the other thing, at least we're seeing on the fellowship assessment, is lots of people right now aren't filling them out when they're at like the level 1s and 2s of entrustability. It's like, once I get to the point where I'm letting them do a decent amount of the case, then I'm filling them out. And so one of our challenges is we've got to get people filling them out for every case from day one of fellowship, so that they see, well, this was a harder case. I wasn't quite as trustable. This was an easier case. I was more trustable. And so hopefully you watch that waxing and waning, but the trend is increasing trustability over time. Now, interestingly, nobody's asked the question, what happens if you're fully trustable in everything by the end of PGY 4 a year?
So that actually people are asking that question. The AMA has funded a pilot project at Mass General. They're calling it right now promotion in place. And if you can reach that, you can actually be faculty for appendectomy or cholecystectomy or whatever. They're not going to let you finish early, but they will give you a documentable better autonomy experience if you can prove yourself competent by the end of whatever year. And so that's being piloted. You know, we're probably 20 years away from you can graduate in 3.5 years instead of 5 years. And the truth is, you know, competency-based training, both of our board speakers referred to Dr. Halstead and the Johns Hopkins program that is the model we're all built on now. Well, what wasn't mentioned, and I don't know the exact numbers, but I'm in the ballpark. In 30 years as chair, Halstead graduated 13 chiefs, okay, and started around 150 surgeons. So had a 90% attrition rate and only one every other year meeting his competency standards. And so how we're going to truly be competent in 5 years is going to be a real challenge. I actually find it kind of humorous that the reason we're trying to move to competency is because we've got a lot of good data that shows in 5 years, we're not training fully competent surgeons. And somehow people are taking that discussion to now we can graduate them in 4 years. I think if we did full competency assessment right now, we document that half of our people aren't ready at 5 years and they need 6. And so to turn that into 4 is a connection I struggle to make.
So I talked to George Sorosi about this exact question, and George was involved in the original manuscript that was published about EPAs by the board. And he also thought there might be opportunity for people who became entrustable, say midway between the chief year, to focus their last half of the year on whatever career interest or fellowship that they wanted to explore, provided the minimum cases had been achieved in all the designated areas. So maybe create some flexibility, but there was no suggestion that anyone would finish early. The question that no one has been able to answer for me is, when a resident is not entrustable at the end of 5 years, can you hold them over, and who's going to fund that? You know, so it definitely raises some questions.
Well, thanks, everybody. This was, we're a little over time. The first scientific session does start in 5 minutes, but thank you all. And the panelists are all around if other questions come up.